Good day, everybody. This is Skender Daerti welcoming you to another episode of the Medtech Business Academy podcast, sponsored by your medtech experts. I have the privilege today of being joined by my esteemed panelists, Barbara Strain and Scott Alexander. Welcome, Barbara. Welcome, Scott.
I think to be
Hey,
here.
Skender.
So, as we're talking about right now, as we're recording, some of the things we're talking about, some recent hospital earnings came out, and yet we're talking about the kind of the dichotomy of where some provider earnings are versus some of the sentiment we're hearing from providers and suppliers, right? And we don't need to get into the specifics of who, what, or when it was, but just recently, as we record this, somebody showcased, and we're proud to showcase to the investing public that they had earned, the hospital system had earned a 5.6 or 5+% operating margin, which is astounding, right? I remember when I came into this industry, the hospitals and grocery stores were pretty much operating on the same line. And 2 to 3% put you in the 90th percentile. So here we are now, they're talking about 5.6, right? And I don't know if that's the 90th percentile, the 80th percentile. Pretty damn good though, especially
Hmm.
when you're talking about a line item that is likely it starts with a B, right? So I don't know if that's 10 billion or 20 billion, but it's a pretty healthy number when you get there. Yet some of the things we were talking about is again coming back to the people who feed that operating margin, okay, in the providers. We're not sure if the providers are all of a sudden sitting there and being like, yeah, we feel good. All we keep hearing from various providers is it's tougher. Reimbursements are down. I can't get anything I want. There's so much pressure on me. I have to do more procedures to meet my IRVU quota. They have scorecards put out on me in terms of my cost per procedure and all these things. And yes, all those little things add up to 5.6%. But then we're hearing it from our suppliers as well, who are sitting there and being like, this is tough. It's hard to get anything through. So, Scott, Barbara, just tell me, are you guys hearing the same sentiment out there?
I know I have been. I've been to several meetings, working on some prep for some panels, uh, talking to lots of people. That's what I hear. And the physicians, we had a little conversation before, is we remember probably at least 6 or 7 years ago or so, there wasn't as many employed physicians. And now it seems to be a large percentage are employed because they just couldn't make it on their own, no matter how they tried to do or affiliate or whatever happened. And talking with some voice of customers sort of information that working on over months and things is supply chain and leadership in organizations are having, physician scorecards.
Hmm.
And physicians are saying, unless it's super high value, and it's going to look favorably to me or my practice or my other fellow physicians, I'm not even probably going to entertain it or even support it as something that should be brought in. So it's very difficult.
Yeah, I we're seeing the same thing, and I wonder if the two pieces are connected. Right, we're seeing this hesitance and reticence to bring new technologies in, and we're seeing an improvement on the operating margins for particularly the larger health systems. We'll talk a bit about rural health here in a minute, sort of the tale of two cities that's going on there. But I wonder to some degree if the challenges that are being faced by medical technology companies is part and parcel with what is driving this profitability increase that we've been seeing.
Yeah, I mean, if you ask most of the provider community, right, they'll tell you that the bean counters are
Mm-hmm.
running everything,
Yeah.
right? And so what are the bean counters like? Is they like less variability, more
Mm-hmm.
predictability, right? Because
Mm-hmm.
they can project off of those. Their numbers make sense. They can't necessarily guarantee their census numbers all the time, but history teaches them that in some capacity, my census in this quarter should be X.
Mm-hmm.
And therefore, if we do that, the procedural mix will be Y, and we can look
Mm-hmm.
at it, right? So variability has been brought to a halt.
Yeah.
And that's why you see 5.6%. But I don't know. This podcast is primarily focused on the supplier community.
Right.
And one of the things that I keep thinking about is so many suppliers are still trying, when you look at how a hospital, and Barbara, we'll turn the table to you here, but there's three levers that a hospital looks at and bringing in new technology, right? Patient care, cost savings, and revenue improvements in some capacity, right?
Mm-hmm.
It feels like two of those levers have been virtually exhausted and they're not getting the same squeeze that they used to. Okay. Can you still improve care? Yeah. But if it's incremental, is it worth the
Mm-hmm.
time investment to bring that in? Right. And that's shitty to think about if we all think about it from the patient perspective. But yes, that is an aspect, right? If the
Mm-hmm.
cost savings are modest, is it worth it to go through the effort, right? But if you can show me a revenue increase and actually show a sound revenue increase, that could be something. But I don't think the suppliers know how to play the game when the first two, which is what they've relied on forever, in some capacity, are
Mm-hmm.
exhausted. I don't know, Barbara, what do you think?
Yeah. Well, you got to throw in one more little factor. So, CMS, in some fashion, how they're working, is they're almost throwing things and forcing things more in that ambulatory surgery center
Yes,
realm.
absolutely.
And when that happens, the hospital that owns them or affiliated with them, the patients that they were getting money from and that they have staffed and they have OR rooms or procedure rooms now are going to these same day, few hours for a procedure. They're staying in the outpatient realm. And do they actually then invest more in the hospital? Right now, they're kind of figuring out how do I get that money back? Because
Mm-hmm.
they don't want to split up and give the money. But I just sit back and say, but if you're not getting the patients, why do you need the money at the level you were entertaining a year ago? You've got to think differently. So,
Mm-hmm.
what I always say to providers is control what you already own. And to your point, let's standardize that. Let's become as efficient as we can. Let's become, utilization experts of what are we doing with our various procedures? Because face it, the OR and the procedure areas are kind of the king of bringing in the funds to help to support like the ED and all the variety of folks you have. And I'm right now telling people they need to be looking at their profitability reports very seriously, procedure by procedure. And where you have those lost leaders cases that aren't sort of standardized throughout, like just take lap appy, for instance, very popular, very high. But if you've got, I don't know, 15 different doctors performing them in your system, and they all have a variability of supplies and various care and that kind of stuff, even though for the most part, their patients, same. You've got to look at all that. That's what you can control internally.
Mm-hmm.
So there are those things that you have to look at as well.
I think one of the pieces too, when we start to talk about providing value, whether it's financial, operational, clinical, kind of you name it, it's not just are you greater than zero. It's are you greater than the 50 other initiatives that are banging on your door.
Yes.
And I think that's one of the things that we all need to be very mindful of is like you have to be able to provide value above the next best thing that's out there because when I was working for the health system, I could spend my days on any number of initiatives, and I had to be really specific. And I had to be thinking about my team. I had to be really specific about where they spend their time because otherwise, you're working on something to pick up pennies when there are dollars over there, and there are dollars, both financial, like literal dollars, but also like from a value patient care perspective, dollars versus pennies. Like those are decisions that have to be made. Um, by the way, back to that health system that we talked about with their success, the bottom line improvements that we saw, it was driven by patient acuity and managing expenses. So revenue is up 12%, expenses only up 9%, and the vast majority of those expenses were pharmaceuticals and franchise fees. So what we're seeing, like I don't know what franchising fees are, but in this context, but it's very much like the people are not they're not adding headcount to the same degree, which means that there's not enough, not as many opportunities to get somebody excited about it. People are being told to do more with less, and the costs are going to the pharmaceutical industry. Is really what the growth means.
So what does it mean to manage acuity?
I think it's just that they
Length
had
is
higher. I mean, it's PDI. It's maybe.
two things.
Oh, go ahead, Barbara. Yeah.
Two things. Sorry, that brain cell may disappear in the next 30 seconds. Two things is keep the patients out of the hospital, managing them in primary care. So if they do have to come in, they're in better health and don't have longer lengths of stay. But you're also trying to manage that length of stay for acuity. So length of stay and acuity go hand in hand because what happens is if the acuity goes up and they're sicker, you're spending more on supplies and other services, but getting the same DRG payment. If their length of stay, which can be complicated by the acuity, that goes up, then the same thing happens. And then it drives CFOs crazy because they can't control that. So it's really that clinical and operational piece that really is the Rubik's Cube pieces that have to be done. And that's where you all have to work together. And that's where I'll mention it. Value analysis can really help you there because they look at that whole picture from soup to nuts.
Yeah, I now I didn't know I get a better sense. Yeah, that absolutely makes sense, right? If you're getting paid fixed amount, no matter what, essentially, which is what the DRG states, then you either maximize by decreasing your cost, your care, blah 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 in that time. So yeah, um, I guess my general sense, and we do a lot of voice of customer with a lot of providers. Okay, I will tell you, and I get an overwhelming sense that there is just a general malaise and indifference amongst the providers. And I'm talking about the clinical providers, not the hospital. I'm not talking about hospital. I'm talking about just providers in general. That there is a general malaise and indifference out there. I don't know if that's a controversial thing to say. I don't know if that's something that, any patient wants to think about that, man, my doctor is just kind of mailing it in, right? But I really do feel like obviously we have those that are in it for the right reasons and they took the Hippocratic oath and do no harm and minister the best care possible. But I feel like there's so many more people when I talk to them, and fortunately, I have the good fortune of being friends with a lot of providers. You know,
Mm-hmm.
they're on the softball field and somebody falls down. They're not running. They are not running to be there, right? As a matter of fact, some of them run the other way before somebody's like, "Oh, Joe's a doctor." And most of them are like they're in their car already running before somebody notices them,
Mm-hmm.
right? Like, I don't want anybody to call me out, you know? Um, But that's the general sense that I get. And I feel like it's because of what we're talking about here, right? The bean counters have beaten them up
Mhm.
so much. I don't know. What do you guys think of that? Barbara, you were kind of nodding your head.
Well, I
Or should
think
we
it's very geographical
okay.
and culture driven in a lot of areas. And I know more provider providers that are really getting more involved because they want to know, they want to understand, and how can they work together to provide that care for their community and those patients who come in. So there's different parts. And so it just depends, I think, on where they started in their careers and what has transpired. But the revenue piece of it, and if you are an employee of a health system, then how is all that sort of uh, described to them? And how does it really happen? And what is that reality of it? And if they're asked to do other things in an organization, like could you help be the quality person, say, in the OR? And could you be on a value analysis committee? And could you also be a fractional or part-time or even full-time member of supply chain as a like a CMO type supply chain or something? It's they need to be paid for that. So that's all part of those conversations. So there's just, I think it's very, very geographical. And we can get into that when we talk about, if we're going to talk about the sort of the critical access and all that kind of stuff, the opposite side of what we've been mentioning.
I think um, I probably fall somewhere in the middle, but a little bit more towards what you're seeing, Skender, in terms of I just see a general fatigue.
Yeah.
Um, I see a fatigue of like physicians, nurses, everybody's being asked to do more with less. We're seeing top line growth, like from a financial standpoint, top line growth, headcount staying the same or only up slightly. Like it just this very much feels like an optimization phase where they're going to get as much, like they being the health systems are getting as much out of employee profitability as they possibly can. Um, because again, I mean, these are always ever shifting things. And what inevitably is going to happen is the fist fight that happens between payers and providers is going to shift the other way. Right. And so it's
Mhm.
going to, this, I feel like what we're seeing in the industry overall is the the physicians, the nurses, the caregivers on the ground are being asked to do more, and that value that's being created is in the fist fight between the payers and the providers, and it's just going to get suctioned away. Is unfortunate,
Mhm.
and so I don't think they have the energy to do the things. And these are amazing, well-intentioned, driven folks, and just my heart breaks for them.
Does
Mhm.
yeah, I agree. I agree. And I think, Barbara, you brought it up and Scott, you kind of alluded to it before, right? When you look at that in the rural setting,
Mm-hmm.
right? It's even more challenging. We just did a discussion and we had a number of ER docs on and we had some from urban, some from suburban, and there was one that was from an extremely rural area, right? And he just raised the discussion, took the conversation over. He was like, "Hey, when somebody comes in and they jab something in their eye, what do you do?" And they're like, "Oh, well, we triage it, we make sure it's okay, and then we send them to the ophthalmologist." He goes, I'm the ophthalmologist also, right? When somebody comes in and they've got this problem, what do you do? And they're like, oh, we send them to that specialist. He goes, I'm that specialist too, right?
Mm-hmm.
Like it's surprised, it's me, he's like my patient satisfaction scores, like, he goes, if they could ever divide them into six, that's what they should do. It'd be like, how do you rate your ophthalmologist? Well, it's the same guy, check, right? Like, what do we do here?
Mhm.
And shockingly, he was probably the most excited
Mhm.
of them all,
Mhm.
right? He was the most passionate of them
I
all,
can see that. Yeah.
right? the hardest job. I don't
Hmm.
know if his compensation measures with the
I'm
same as the
sure it doesn't.
guy that we had from New York. I'm sure it doesn't. I'm sure it's fractional.
Hmm.
Okay. But certainly there is a different mindset there. Yet all we keep hearing is the cuts are completely disproportionate. He doesn't
Hmm.
have those specialists because those specialists don't want to be there,
Hmm.
right? The hospital systems around those rural areas are getting cut. They don't want to pay for them. So what continues to happen in those areas? How do we, if you're a supplier, what are you thinking?
Yeah, I think we need to get the conversation back to the suppliers because one thing, just doing the sort of the critical access rural, I know there's a lot of energy like at ARM, which is the Association for Healthcare Resource Material Managers, and a variety of organizations. They have the Independent Link Coalition and a variety of folks kind of grassroots trying to get suppliers and others involved because most of the, say, the market with certain companies and things is they're going after other areas because they know that the money is not available in those rural critical access areas. But those people who live in those areas are no different than a person who lives next door to you,
Hmm.
across the street, across the country, or whatever. They're all people and they all have problems that need to have care. And if those hospitals or centers, and most of them are connected to lots of clinics that see people at very little dollars going their way, if that goes away, most of those people may not seek care elsewhere an hour or 2 hours away. And so then when they really do get sick and have to be either ambulance or they have to be carried by a helicopter somewhere, then they're going to be in the hospital a long time and have lots of complications. So we're cutting off the blood supply to the main part of things so prematurely because you need to keep people in their communities out of the hospital. So those providers that work in those ED situations or in 25-bed hospitals or whatever they are, they have a passion to make sure that those people that they live in their communities or things are being taken care of. Otherwise, it may not happen, or it may happen sporadically, like once a year with a some sort of free, clinic offerings or anything like that. So as suppliers, you need to have some sort of carve out of some sort that you need to have a business entity that can take care of these rural. Are they going to have Da Vinci's all over the place? Are they going to have all these fancy pieces of equipment? But find out what they do need and how can you connect to that? And there's somehow, this is me being Pollyanna, I know, but there needs to be some sort of, I know you guys are smiling, but there needs to be some sort of connectivity among the whole healthcare industry, that they have some sort of plan to help those folks. They will get some sort of reward for it and they'll get some business. But right now, it's just haves and have nots.
I wish that I think that we have lost the should in healthcare. And
Mhm.
I'm going to channel my father, who's a, rural health guy, turned ER doc in a rural committee. So my name is now Dr. Paul Michael Alexander. Um, Look, we've lost that, and it is never coming back. We are absolutely in the optimization phase of healthcare, and everything is pointing towards that. And I think so. Therefore, like should is not a word that exists in our industry anymore, unfortunately. Um, but I think to the point that you make, Barbara, I think that there's a lot that can be done in the rural health setting. If I'm a manufacturer There's a lot that can be done in the rural health setting that would take you forever to, you would never be able to do it at a larger health system.
Right.
And let me tie a couple of thoughts together. So one of the things that we talked about earlier is you have to be able to show value. When I was at my health system, and when I advise companies now, very few companies are able to really show value. They're like, yeah, just trust me, essentially is what the pitch comes down to. And the truth of the matter is you have a ready, willing, and super eager population of rural health organizations that would love your awesome technology and would be more than engaged to say, yeah, let's figure out if we can reduce length of stay for heart failure patients. So let's figure out if we can do X or do Y or do Z and publish that and use those data to then get in to make the arguments to these larger organizations. I, I'm I'm not a should guy. Like I'm a little bit overly pragmatic on much of life, and so this is one of those things where you can be entirely selfish. And I'm not a very selfish guy, but just go with me. You can be entirely selfish and help out these organizations that Barbara you're describing need all the help because it's completely in your best interest to do so in a way that
Mhm.
you cannot do. And I just think it takes a little bit more forethought, particularly as you're thinking about the evidence creation phase of your business, because I'm going to tell everybody who's listening right now, right? The decision making process for a value analysis committee comes down to three things: it's clinical, it's financial, it's operational. The clinical story of like, wouldn't it be cool if fill in the blank is super easy. The data piece of creating it is a little bit more difficult, but we kind of have that down. The financial and operational considerations, if you're listening to this, you're probably not doing it well. Like, sorry, I'm cranky as we're eating. I haven't had lunch yet, so
Oh
forgive me for
no.
being cranky, but you probably haven't figured it out. That is what's keeping you from being adopted by the Christuses, the Geisingers, the fill in the blank Saint Somewheres that you want to get into. Well, you can go figure those things out in 6 to 12 months by going and finding these rural health centers and putting the proof where the pudding is, right? Or whatever, what the phrase is that I'm trying to say.
Yeah.
Like, go do that. And then it becomes so much easier to get into these other larger health systems is where you're going to make your money. But you can do a lot more work without having to like sit on the sidelines. And the last thought, and then I'll stop and take a breath. If you were a startup, I talk to startups every day and they're like, hey, can you just help me get into fill in the blank? Because they won't answer my call. If you are finding that's the case, pick up the phone and call Dr. Smith, that ophthalmologist slash cardiologist slash nephrologist, and see if he'd engage with you. Because the reality is there's a lot of those folks out there. They have great insights about the totality of care. And you can start a trial in, middle of nowhere, Missouri with no head like burden contrasted to BJC or Mercy or SSM or whatever. So anyway, that's my thought is like you can help rural health in a way that's going to help you. You just need to think about it differently.
Yep. Great.
I think it's actually brilliant. I really do. I think
Hmm.
I think so many, again, the expectations across the world are so different, right? I remember when I came into this industry, you'd see entrepreneurs who are doctors, engineers, and they had a whole mindset of, I want to be a big company and I'm going to go at slow and steady. Once everybody had the idea of, I'm going to go raise 15 million. Right.
Mm-hmm.
Well, once you raise that 15 million, if you get it, first of all, you never get 15 million, you get 3 million first. And then it's like that's tied to a time-based volume milestone to get the other 3 million before they release the final 9 million to you. Right. So it's changed all the perspectives. And so I think most of these people like, I hear what you're saying, Scott, but I don't have time to go into middle Kansas. Like,
Yeah.
unless it's for University of Kansas, right? Like, I don't have that time. My investors, if I show them, hey, guess what? We got Chippewa Falls Hospital, they're gonna be
Mm-hmm.
like, and how many beds is that? That's 15. Yeah. Guess what? You're not gonna get the other $4 million tranche.
Mm-hmm. I mean, I think it's a good statement. I think at the end of the day, though, the argument that I would make as somebody who worked for I got worked for a venture capital fund. I don't. I don't think you can stop trying to go after University of Kansas. I think it has to be that and Chippewa Falls because, like th- that's where you're learning, right? And if you're thinking about yourself as a startup, like you go back to Steve Blank and what he talks about as like the definition of a startup is an organization that's learning as quickly as it can. That's essentially what he says. And the
Failing
truth of the
fast.
matter is, how much time are you sitting in your chair waiting for the University of Kansas to call you back? You could be gathering data in the greater Kansas area. And by the way, these people know each other. So I just think it's short sighted to sit around and wait for one of these bigger health systems to call you back when the truth of the matter is you can keep calling them, but you're not doing that 40 hours a week. So anyway, that's my reaction to that.
Yeah, I love it. Love it. That was great. Great insight. Let's wrap this up here. Barbara, why don't you wrap it up?
So my final thoughts are, I think we can all agree that we experience so many suppliers that feel so frustrated because they don't get the call back or they don't get the yes, even though they've invested 6 months, with courting someone who's looking at them and things. So going along with Scott's sort of idea is take a fraction of your time and what you're doing and go seek out some of these other smaller places and even do assessments or do a let me walk in your shoes for a few hours and see what's going on and see, hey, I know my company can help and have rally around, your company and do a groundswell from sort of within that, hey, we should be doing some of these things all over in our territories and pick one and see what we can do and then bring back that information and things. So, yeah, I'm not giving up on Pollyanna, but yeah.
Yeah,
Good.
I think my final thoughts. Um, it's going to be consistent, and maybe I'm sounding like a broken record, but I feel like the takeaways that I would encourage somebody to have is figure out how you can hone in and sharpen up your value propositions in a way that's meaningful and separates you from all the noise that's facing health systems, whether it's the largest of the large IDNs or rural health or anywhere in between. I feel like you've got to figure out how to tell your story better, or else you're going to continue to have this cycle of not getting the progress that you're wanting. And if you find that you don't have the data or the access or whatever the case might be, there are avenues to get access to clinical settings that are just maybe a little bit less traditional than you would typically think.
Yeah. I'm inspired by your words, Scott. I think the creativity that has to go out there, right? We hone the great baseball player, Wee Willie Keeler, who said, hit him where they ain't, right?
Yep.
And so going from that perspective, looking at Chippewa Falls isn't always the sexiest thing.
Mm-hmm.
But as far as, we all know sales growth is really a momentum game.
Mm-hmm.
And you can't have any momentum if you don't start with some movement. And so I love that idea. And you know what, Barbara, to your point, those small rural critical care hospitals, they are usually the most passionate. They have the most need right now. They're the ones that are so motivated by so much. Go there, get that momentum, get that opportunity. That's what I think is the takeaway from today.
Mm-hmm.
Good. Well, thank you both. Appreciate it. Thank you to our audience. If you like what we have to say, please like, subscribe, tell us, hit us up with questions. If you don't like what we have to say, we don't care. We're going to say it anyway. So thanks, everybody. Appreciate it. Have a great day.
Thanks, y'all.
Yep. Thanks.